Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week it's a conversation about liver cancer with Dr. Tamar Taddei. Dr. Taddei is a professor of medicine and digestive diseases at the Yale School of Medicine. Here's Dr. Weiner.
Before we get going, can you just tell me a little bit about you?
Sure. So I grew up in Bethesda, Maryland, right outside of NIH, and I came to Connecticut in 2004 for my GI fellowship. I've been at Yale ever since, and that's me in a nutshell. Child of scientists, and very excited to be studying what I'm studying.
And you're based at the VA. I think some people are very familiar with the VA system. Others are less familiar. Tell us a little bit about what it's like to work at the VA.
So for me, the VA is the ideal place to do both research and clinical care. Because I'm a hepatologist, the VA is the largest provider of liver care in the United States. It is a national health system with essentially stations and medical centers all over the U.S. and the U.S. territories. And so because of the fact that we provide so much liver care and because there's a higher prevalence of liver disease in the VA, I get to see the patients that I've trained to see, and I get to answer really interesting research questions that I've learned to ask along the way.
And I know you'll be touching on this a little later as well, but to what extent do you get to work with VA hospitals throughout our country?
So the VA has national program offices for every specialty type of care. So there's a national oncology program office, there's a national GI and hepatology program office, and the national offices actually create policy and metrics for the entire VA. And as a provider here in West Haven, I'm actually talking to the national office all the time, and I'm carrying forth national metrics like liver cancer screening, like colorectal cancer screening. And we're actually graded on these metrics, and there's a fantastic central office to field communication where there's a field advisory board that helps to drive both policy and metrics. So we actually deal with stations all over the country. I have friends all over the country, and my research is all over the VA. So I'm, very well linked to local site investigators all over the country.
Well, that's great. And so before we talk specifically about some of the facts related to liver cancer, maybe you could just tell us a little bit about your own clinical expertise and the areas of research that most fascinate you.
Sure, I'd be delighted. So my clinical expertise is in liver disease or hepatology, and I focus really at the end stage of cirrhosis and hepatic decompensation when the liver is not able to function, and also in liver cancer. And my research niche really is liver cancer. I became interested in liver cancer as a fellow when I was invited to run Liver Tumor Board, which was really exciting to me. And I was given a lot of autonomy as a fellow once I sort of learned the ropes to stand in for attendings to run that particular tumor board. And I began to really think about patients with liver cancer and just how heterogeneous their presentations can be. Each person presented differently. Each person made me think about new questions. And I then parlayed that into my research focus. So my clinical work is really entirely centered on cirrhosis, liver cancer, and palliative care in liver disease, which I have a strong interest in. And so that's sort of what I've done. I've built tumor boards in New England. So I run a regional tumor board that covers a bunch of different states so that we can all have a good plan of care for each of our patients. And I'm very interested in multidisciplinary management of patients and sort of the group dynamics that make a successful plan for a patient and make a patient feel like they have a team behind them. That's really important to me, is that, each patient is sort of the most valuable player on their team. and to have a team behind them really speaking the same language, coming to consensus, that's a vital part of complex care. So that's what I do.
So you mentioned cirrhosis and you mentioned liver cancer. Maybe you could tell us a little bit about the connection between the two.
Sure. So cirrhosis is the final pathway of liver fibrosis or scarring. Okay. So fibrosis happens over years in the liver and is usually a response to inflammation and the liver's sort of drive to heal. The liver can actually make scar, and that scar covers the whole liver, not just a piece of it. And this happens over years after exposure to a particular injury to the liver. And that injury could be anything. It could be a viral infection. It could be, chronic heavy alcohol use. It could be certain disorders of metabolism. It could be toxic exposure, for example. So there's a lot of different insults that the liver can endure and can become inflamed and then develop this scarring that happens uniformly. And once the scarring reaches a critical threshold, we call that cirrhosis. And everybody with cirrhosis is at risk of developing liver cancer. And that risk increases over time. So we have to be very careful to make sure that we can identify cirrhosis, which can be kind of challenging, actually. And then make sure that once we know a person has cirrhosis, that they're involved in a routine surveillance program for liver cancer. So that's how they're linked. And it's really important because oftentimes cirrhosis goes undiagnosed. So the problem is there may be many people who have cirrhosis, don't know it, and they're at risk for liver cancer and they're not getting screened.
And you mentioned viral hepatitis. What viruses are we talking about here? For years, people talked about hepatitis B, and of course, more recently, there's been a great deal of focus on hepatitis C.
Right. So hepatitis B and hepatitis C are chronic hepatitides, we call them. They're chronic viral infections. And in hepatitis B, that virus can actually cause cancer without cirrhosis. So people with chronic hepatitis B should be in a liver cancer screening program. And people
Can I just stop you for 1 second?
Yeah, please.
And is that somebody who ever had hepatitis B or someone who has chronic ongoing hepatitis B?
So that's
infection?
Chronic ongoing hepatitis B. And this is really important. So about 90% of adults who contract hepatitis B in adulthood will clear the virus. But most hepatitis B that becomes chronic is a result of acquiring hepatitis B in the birth canal. So basically you're acquiring it at birth from your mother, or acquiring it in early infancy, where the immune system simply doesn't clear the virus. It basically doesn't see it. And so chronic hepatitis B can, it basically intercalates or becomes part of the host DNA. And doing that, it has carcinogenic potential that's different than just the development of cirrhosis. The truth is that most people with chronic hepatitis B who develop liver cancer have some degree of fibrosis of the liver, but they may not have cirrhosis. And we know they have chronic hepatitis B because they have either a detectable viral load in their bloodstream or their viral load has been suppressed with antiviral medications. And they have a certain antibody panel that shows that they have a chronic infection. And so there's a lot of testing that's done in people with hepatitis B or suspected hepatitis B to really determine what is their immune state. Have they seen the virus and cleared it on their own? Do they have chronic infection and need to have their virus suppressed? Are they a new case of hepatitis B?
So the hepatitis B virus in these people who have chronic hepatitis B actually becomes part of the liver itself or part of the liver cell itself.
Yes, it does.
And treatments for hepatitis B, they didn't used to exist and now they do?
So there are excellent antiviral therapies for hepatitis B now. And we can suppress hepatitis B effectively. And we know that if we can suppress the virus, we dramatically reduce the risk of cancer. There are many groups studying ways of actually curing hepatitis B. And I think we may be on the verge of finding the right drugs to do that, but we're not there yet. However, like I said, viral suppression is key and dramatically reduces not only the risk of liver cancer, but the risk of progression of fibrosis to cirrhosis.
And speaking of cure, hepatitis C, on the other hand, we do cure, correct?
Exactly. And that's why it's been in the news so much, because it is curable. About 98% of people can achieve a cure with a few weeks of medications. These are all oral medications. They're very well tolerated. And we're talking about anywhere from 8 to 12 weeks of therapy, after which a patient can achieve a cure, and it's a durable cure. You can be reinfected with hepatitis C. So the behaviors that perhaps, or exposures that perhaps led to the hepatitis C infection in the first place, you'd have to still maintain, care to avoid those. But once you're cured of hepatitis C, your risk of liver cancer goes down dramatically. And if you didn't have cirrhosis when you started your hepatitis C therapy, chances are you will not progress to cirrhosis after treatment unless there's some other injury that the liver sustains. So that's like a phenomenal development in medicine. It's probably the most intense, sort of fantastic thing I've witnessed in my career, because for many years, all we could offer was a combination of drugs that had really terrible side effects. And only about 50% of patients actually achieved a cure after a year of enduring horrible, horrible side effects. Now we have, like I said, all oral combinations. People can be cured in 8 to 12 weeks. It's phenomenal. So the CDC actually released guidance back in August of 2012 that said that any adult should be tested for hepatitis C and treated. So at this point, we're really trying to test and treat the nation. And hopefully we'll get there. We're a little bit behind the goals that we set once these cures became available in 2014. But the VA is a shining example of success. We've treated over 100,000 veterans of their hepatitis C. Only the hardest to reach have yet to be treated.
And before we get into other causes of cirrhosis, in terms of hepatitis C, how is it that people get it?
So I want to start by saying that roughly 30% of people who have hepatitis C have no clue how they got it. And that's important. But hepatitis C is usually contracted by blood, and that can be by blood transfusion. That can be by any, for example, IV drug use, even intranasal cocaine use. So exposure to blood is how most people have contracted hepatitis C.
Got it. So we're going to take a 1-minute break now. Please stay tuned to learn more about the treatment of liver disease and specifically liver cancer with my guest, Dr. Tamar Taddei.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their screening and prevention program recommends that everyone perform monthly head-to-toe self-examination of their skin and protect themselves from the sun year-round. SmiloCancerHospital.org. The American Cancer Society estimates that more than 65,000 Americans will be diagnosed with head and neck cancer this year, making up about 4% of all cancers diagnosed. When detected early, however, head and neck cancers are easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for head and neck cancers. Yale Cancer Center was recently awarded grants from the National Institutes of Health to fund the Yale Head and Neck Cancer Specialized Program of Research Excellence, or SPORE, to address critical barriers to treatment of head and neck squamous cell carcinoma due to resistance to immune, DNA damaging, and targeted therapy. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Eric Weiner, and I'm here with my guest, Dr. Tamar Taddei, an expert in liver disease and specifically liver cancer. We're going to talk more about what causes liver cancer and about treatments for liver cancer. So we've talked about hepatitis, that is viral hepatitis. And we touched earlier a little bit on other types of damage to the liver. Of course, for many, many years, many people associated cirrhosis with excessive use of alcohol. To what extent is that still a major problem?
It's still a major problem. And the thing is that it's sort of the 500-pound, elephant in the room, in the sense that alcohol use disorder and excessive alcohol intake, they're very hard to tackle. And they're more than medical problems. They're social problems as well. And they really require a dedicated team. I would say that alcohol is still what we see most of in the clinical setting, is the underlying injury to the liver. And the problem is that it's you might say, well, it's a dose response, but it's not. So there are people who can drink quite a bit of alcohol and not sustain liver injury. And there are people who actually don't have to drink too much alcohol to sustain a liver injury. And so this is the problem. It's very hard to counsel people because we don't have biomarkers to know who's at risk for alcohol-related liver disease and who isn't. The other problem is that alcohol-associated hepatitis is a life-threatening problem. And most people who present with alcohol-associated hepatitis have some degree of underlying scar in the liver, if not frank cirrhosis. And they are very, very sick. So the field is evolving to try to think of who's the best type of person with alcohol-associated hepatitis to receive a life-saving liver transplant, because about 50% of people who present with alcohol-associated hepatitis die within the first 6 months or so. If it's very severe, yeah. So transplant is moving to try to figure out the best way to treat this very vulnerable population. It's a major problem, and I think the other problem is that alcohol is not just sort of used in isolation, in the sense that excessive behaviors like excessive drinking and excessive eating, for example, sometimes go hand in hand. And we have a lot of metabolic liver disease that we see in patients who have obesity or who have diabetes. And many of these people may also be drinking excessively, and that compounds the injury because they're already aberrantly handling their fat, and their livers are becoming infiltrated with fat cells that are inflammatory, and then they may be drinking as well. So alcohol is a cofactor for a lot of liver disease, and it also underlies a lot of primary liver disease. It's a big problem.
So you touched on diabetes, and I think started to comment on what's often called fatty liver disease, something that when I was in training quite a number of years ago, we hardly ever talked about. But fatty liver disease is a real problem and seems to be something that is, if not more frequently recognized. Can you talk a little bit about that?
Yes. So fatty liver disease now has a new nomenclature. It's called metabolic dysfunction associated steatotic liver disease, or MASLD. This nomenclature is to try to drive home to people that it's not associated with being fat per se. It is associated with a state of overnutrition, which drives metabolic derangements in the body. And this basically results in inflammation of the liver, because the fat cells in the liver exert an inflammatory effect, and they cause inflammation, and that's followed by scarring. And not everybody develops fibrosis or cirrhosis who has fat in the liver. But again, we lack biomarkers to know those who are truly at risk. At this point, about 100 million Americans likely have some degree of fat in their liver. And of that 100 million, a proportion of them may develop fibrosis, and about a quarter of them, so maybe 25 million may develop fibrosis, and another proportion of that may develop cirrhosis. So it is a huge problem. It's not just the metabolic derangements, that affect the liver. Metabolic derangements affect the heart as well. So people have heart disease, and we've gotten very good at managing heart disease. So we're seeing sort of the longer term natural history of the effects on the liver, because many people who might have died of a massive heart attack decades ago are actually living with their heart disease and living long enough to develop liver disease. But we also have significantly more overweight and obesity in the population today. So this is a major public health crisis. And we need to really think about how we eat and how we move as a population, because we're becoming a sick society. And I think, all of this fatty liver disease or metabolic dysfunction associated liver disease is just a sort of a window onto our, practices in terms of how we eat, how we move, and how we don't prioritize our own individual wellness. I think sort of the way I look at medicine is how much could we prevent? And I think that we end up thinking about treating damage when damage is done. We ought to think about how to prevent that damage in the first place.
So as a result of what is still a problem with alcohol use and alcohol-associated liver disease and hepatitis C and this increasing number of people with metabolic liver disease, how common is liver cancer today? It seems that it is a fair amount more common than it was 20 and 30 years ago.
It is. So globally, it's the third leading cause of cancer mortality across the globe. So in 2020, there were about 830,000 deaths from liver cancer, almost 1 million. Right.
And much of that is related to hepatitis in many
Correct.
countries around the world.
Correct. And, they're estimating that sometime by 2040, we should see somewhere around 1.3 million deaths globally. In the U.S., we have on average about 42,000 cases a year, and that's predicted for this year, and about 29,000 deaths per year. It doesn't sound like much per se, but it's actually a highly lethal cancer. So the problem with liver cancer is that it's often caught in later stages, and the 5-year survival is, barely at 20%. So this is a huge problem, and it is on the rise. And it's on the rise now. We're seeing actually an epidemiological shift towards people with fatty, with metabolic liver disease. And that's because the population attributable group is so big, right? There's so many people who have metabolic disorders of the liver. But while we're getting ahead of Hep C, we're treating Hep C and we're hopefully mitigating the risk of Hep C associated cirrhosis and liver cancer.
Well, and to put the numbers in perspective for people, although liver cancer is, for example, far less common than breast cancer, a cancer people talk about a great deal, in terms of the number of deaths, about 2/3 of as many people die of liver cancer as die of breast cancer. So in terms of the mortality, it's really quite significant. Can we talk a little bit about new treatments for liver cancer and how we go about treatment? It's a disease where we really need multiple disciplines involved. And those disciplines include hepatologists and medical oncologists and surgeons and a field that people may be less familiar with, interventional radiology, where radiologists perform certain procedures. Am I missing any?
I think there's increasingly a role for radiation oncologists. I also really like to have palliative care specialists at Tumor Board. So I think you've got most of them.
And so what are some of the new treatments and how is it that they've come to exist? If you could maybe touch on some of the clinical trials that have been done.
Sure. So the new treatments are basically in sort of 3 categories. The first treatment, which is, before I talk about treatments, let's talk about stages. So early stage liver disease is usually treated surgically or by an interventional radiologist.
And by early stage liver disease, you mean early stage liver cancer here.
Yeah, liver cancer, right. So we're talking about maybe, one tumor or, small tumors that are fairly localized to the liver. They can be treated oftentimes by surgery if the underlying liver is healthy enough to withstand a surgery, or by interventional radiology, where they use techniques that can, for example, destroy tissue or deliver chemotherapy right into a tumor and then starve off the tumor's blood supply so it can't recruit new blood vessels and new nutrition. So those are what we call liver-directed therapies or local regional therapies. And they're excellent for early disease, and they can prolong life. In fact, they can prolong life by many, many years. I would say, the latest statistics would suggest that, about 50% of patients can be diagnosed in these earlier stages, and only about 15% of patients in these earlier stages can actually have surgical cure. And that's because their liver is too sick to handle a major surgery. So surgery is reserved for sort of the healthiest of the bunch with the least amount of tumor burden. Once you get into larger tumors or tumors that affect a significant portion of the liver, then you need to think about what we call the transarterial therapies. And those are therapies that can, as I said, deliver chemotherapy to tumors and starve off the blood supply. We can also deliver radiation therapy to tumors. So those transarterial therapies are used for people with intermediate stage liver cancer. So these are people who might have a number of different tumors throughout the liver, or perhaps a large tumor that can't be addressed surgically or by other techniques. And then for more advanced liver cancer, we offer systemic therapy. And this is usually offered for people who have tumors that are diffuse and infiltrating the liver, or that have breached the liver's blood supply. So they're in the vasculature of the liver, or they've gone outside the liver to neighboring organs, most commonly the lungs. And there's three sort of general buckets that we put these treatments into. They're all called systemic therapies. We don't call them chemotherapy because they're not conventional cytotoxic chemotherapy. These are therapies that are targeted to different pathways that cells have, that cancer cells actually have to replicate and to suppress the immune response to cancer. So the first bucket are something called tyrosine kinase inhibitors. And these are drugs that affect a bunch of different mechanisms that cells have to both grow and to recruit their own blood vessels. And these were the first agents that came onto the market. The second group are called immune checkpoint inhibitors, and these are drugs that actually help the body recognize cancer, the immune system to recognize cancer. And then the third bucket is called VEGF inhibitors. Those are vascular endothelial growth factor inhibitors, which actually help the body to not develop new blood vessels around a cancer. So in layman's terms, those three buckets do a lot of different things affecting growth, blood vessels, and the immune system.
And by not growing blood vessels around the tumor, the tumor is essentially starved.
Exactly.
Dr. Tamar Taddei is a professor of medicine and digestive diseases at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.